Hello and welcome to this video on the trigeminal nerve. This video will focus on the first two branches of the trigeminal nerve, as the trigeminal nerve requires quite a lot of dissecting in order to be able to understand its full role. Taking you on this journey is me, Tanya Chamberlain, from the Division of Anatomy here at the University of Leeds. So let's get right to this. As we covered the cranial nerves throughout the whole of the introduction to the oral environment, in 7 lectures, you might be wondering why we are giving 2 lectures to this just one of these 12 cranial nerves. The answer, of course, is that the trigeminal nerve is of huge clinical importance, not just in dentistry, but also in a wider medical context. The trigeminal nerve is going to be a huge deal for you as a professional. The chances are, on a daily basis, you're going to have to anaesthetise a branch of V2 or V3. You need to know where those branches of the relevant nerves run and what they supply in order to do this. So learning the basic anatomy is the very first step in becoming proficient at it. Delivering anaesthesia effectively and with as little pain as possible is one of the key ways that your patients will measure you as a practitioner. So it's worth spending a lot of time to make sure you get this right. Before we finally get to the learning objectives for today, let's just linger on a little wider context of the trigeminal nerve. Here we can see a man who is suffering from a rather nasty case of a condition called herpes zoster, also known as shingles. This is characterised by the presence of lesions in the cutaneous distribution of a nerve, which contains the active varicella zoster virus, the same virus that causes chickenpox. By cutaneous distribution, I mean the skin that receives the supply from this sensory nerve. In this case, the virus has become active in this gentleman's left maxillary nerve. The patient from which this photograph has been taken from suffers from a condition called trigeminal neuralgia. This has been known to be the suicide disease, as the pain it causes can be so severe that some patients have taken their own lives rather than continue to live with it. It is amongst the most painful of medical conditions, along with related diseases such as cluster headaches. Trigeminal neuralgia is characterised by an intense acute pain along the division of the nerve. The pain is paroxysmal. That is, during an attack, it occurs in bursts with pain-free periods in between. It also tends to disappear entirely for extended periods before recurring, an often unpredictable manner. So, after the longest introduction in history, we will finally get to today's learning objectives. By the end of this lecture and any further necessary self-directed study, you should be able to describe the origin of the trigeminal nerve, describe and identify the location of the trigeminal ganglion and the apertures through which the 3 divisions of the nerve leave the cranial cavity, summarise the anatomy of the ophthalmic nerve, describe in detail the maxillary nerve and its branches, describe examples of dental local anaesthetics that can be applied to the branches of the maxillary nerve. So let's go and have a look at an overview of the trigeminal nerve. This picture on the right is the undersurface of the brain. The trigeminal nerve emerges from part of the brain called the brainstem. This is the more primitive region of the brain that is concerned with the transmitting of information between the body and the higher brain centres, and with a whole raft of regulatory and reflex actions, many of which, such as breathing, are vitally important for life. 10 of the 12 cranial nerves emerge from it. The brainstem is made up of several distinct regions. The trigeminal nerve emerges from a region called the pons. It's Latin for the bridge. In this picture you can see the main sensory roots of each trigeminal nerve. These are the parts of the nerve running from the brainstem to the respective trigeminal ganglion. They're quite short, around 1 to 2 centimetres or so, but are clinically important in most cases of trigeminal neuralgia, as they appear to be caused by the artery rubbing against this part of the nerve. Right next to the sensory root, we could see a much smaller root of the nerve. The motor root travels alongside the sensory root ganglion before leaving the cranial cavity with the mandibular nerve. It fuses with V3 just after they both leave the skull. As a result, there are no motor fibres in the ophthalmic or the maxillary nerves, and none within the trigeminal ganglion. Trigeminal motor fibres are only found in the motor root, and in the mandibular branch beyond this point, that the motor root joins it. This complicated diagram shows the trigeminal nerve and its branches. The main sensory root and the ganglion are shown in orange. The ophthalmic nerve and its branches in pink. The maxillary nerve and its branches in teal. And the mandibular nerve and its branches in navy. Let's go and take a look how the divisions of the trigeminal nerve get out of the cranial cavity. In the right and left pictures, we are looking into the cranial cavity with the brain removed. You can see the distinct regions of the cranial base, called the anterior, middle, and posterior cranial fossa. We met these fossa back in Introduction to the Oral Environment. You can see the trigeminal nerve on the left-hand picture. Note how it passes from the posterior cranial fossa to the middle one by running over the petrous, or rock-hard, part of the temporal bone. Once in the medial cranial fossa, the sensory root quickly expands to form the trigeminal ganglion. This is where all of the cell bodies of the trigeminal sensory fibres are located. This is why there is a swelling or ganglion at the nerve at this point. The three divisions of the trigeminal nerve sprout from the ganglion and leave the cranial cavity through three different openings in the skull. All of these openings are in the sphenoid bone. The ophthalmic nerve travels anteriorly to pass through into the orbit through a slit called the supraorbital fissure, which can be seen here. The maxillary nerve also travels forward, but instead of passing through the superior orbital fissure, it goes through a window or an opening called the foramen rotundum, or round foramen. This is most clearly seen in the picture on the right, which shows the cranial base with all the soft tissues removed. The mandibular nerve travels most directly downwards to pass out of the skull through an oval-shaped opening called the foramen ovale. The motor root of the trigeminal nerve travels through the foramen ovale as well. Again, this foramen is best seen in the right-hand picture. So let's go and have a look what it looks like in a real specimen. But first, let's orient ourselves before I bring out the cadaveric image. We are going to be zooming in on this. Over to the right, you can see the eyeball and some of the bones surrounding the orbit that have been removed. To the bottom left, you can see the external ear canal. Towards the very bottom of the picture, you can see the ramus of the mandible, which has been cut away so you can see the structures that would normally be running inside the mandible, as well as into the infratemporal fossa. Large parts of the cranium have been removed so that you can see into the middle and posterior cranial fossa. Over to the left, you can see the sensory root of the trigeminal nerve in the posterior cranial fossa. It's labelled 33. Note the artery labelled 32. This is the vessel often implicated in trigeminal neuralgia, as it can rub against the sensory root of trigeminal nerve. After passing over the petrous ridge, the sensory root expands to form the trigeminal ganglion, which is labelled 34. You can see how this gives off the ophthalmic nerve, the maxillary nerve, and the mandibular nerve. These then pass out of the cranial cavity through the superior orbital fissure, the foramen rotundum, and the foramen ovale respectively. You can't see the motor root of trigeminal nerve in this picture, as it is hidden by the larger sensory root. The trigeminal ganglion and the mandibular nerve, as mentioned, The motor route leaves through the foramen ovale with the mandibular nerve. We are now going to move on and look at 3 of the divisions of the trigeminal nerve in turn. We'll cover V1 and V2 in this video, and V3 the next time. So let's move on and look at the ophthalmic nerve. The ophthalmic nerve emerges from the trigeminal ganglion and runs forward through the middle cranial fossa towards the orbit. Just before reaching the superior orbital fissure, V1 starts to split into its various branches, and they all leave the cranial cavity through this superior orbital fissure. Branches of the ophthalmic nerve provide the sensory supply to the structures in the orbit, including the eye itself. Note that the ophthalmic nerve does not provide the special sense of vision. This is supplied by Cranial Nerve V2, the optic nerve. Some of the branches leave the orbit to supply the skin and the forehead. I can't think of anything really dental to give you about the ophthalmic nerve. This is why you should be able to describe its anatomy in 4 sentences. Let's try. The first division of the trigeminal nerve, V1 the ophthalmic nerve, emerges from the trigeminal ganglion, full stop. It runs anteriorly across the floor of the middle cranial fossa, full stop. It starts to branch just before passing through the superior orbital fissure, full stop. Its branches provide the general sensory supply to the contents of the orbit and the skin of the forehead, full stop. There, easy. So let's move on and look at something much more relevant and interesting, the maxillary nerve. We've already seen the maxillary nerve arises from the trigeminal ganglion and briefly across the floor of the middle cranial fossa, and then leaves the cranial cavity by passing through the foramen rotundum, where it enters the Pterygopalatine Fossa. This is a space between the maxilla and the pterygoid plates of the sphenoid bone and palatine bones. Its overall course is to travel anteriorly and supply the general sensation to the middle face, maxillary teeth, and the palate of the mouth. Remember, we have 2 of these, one for each side of the face, palate, and teeth, though largely I will refer to it as being only one, because it is expected that they will mirror each other. We can also see on this open book image that the medial and lateral walls of the nasal cavity will also feed back the general sensory information to the maxillary nerve too. The slit you can see into the Pterygopalatine Fossa lies between the maxilla and the lateral pterygoid plates of the sphenoid bone. This is called the pterygomaxillary fissure. The pterygomaxillary fissure contains a collection of nerves which arise from the branches of the maxillary nerve, but also something called the Pterygopalatine Ganglion, which is where the facial nerve bodies lie for the secretomotor innervation of the lacrimal glands. You do not need to know any information about this. This is purely to demonstrate where the fibres of the maxillary pass. This image shows the whole of the maxillary, including most of the branches that we need to know about. The close-up shows the maxillary nerve travelling through the Pterygopalatine Fossa and giving off some important branches within the fossa. The round object you can see close up is an autonomic ganglion, like the otic and the submandibular ganglia we met in salivation. This is the Pterygopalatine Ganglion, and it hangs from the maxillary nerve in the Pterygopalatine Fossa. The maxillary nerve sends sensory fibres through the Pterygopalatine Ganglion. They do not do anything in the ganglion, they just pass through it. There are cell bodies and synapses in the ganglion, and this is why it exists, but they have nothing to do with the trigeminal nerve. You do not need to know, but they are the facial nerve secretomotor fibres that do things like make you cry and make your nose run. The ganglion gives off several branches, which carry these sensory fibres to their final destination. We can also see some of the important nerves branching from the maxillary nerve. We have the infraorbital nerve, the pharyngeal nerve, the posterior superior alveolar nerve, the zygomatic temporal, the greater palatine, the lesser palatine, and the whole palatine nerves from which these two latter arise from. We will look at these in more detail in a few moments. This diagram shows the deep surface of the right pterygopalatine ganglion, whereas the previous one we were looking at was from outside of the head. We sawed the head in half, and we are looking at the cut surface of the right side. The teeth you can see are the upper right dentition. You are looking at the lingual surface of the maxillary molars. And our old friend, the trigeminal ganglion, is also visible. In order to see the pterygopalatine ganglion from this view, I've also chipped away at some of the bone. You can see the ganglion gives off branches. Some of these run almost vertically downwards. These are the palatine nerves. The greater palatine nerve emerges onto the palate and runs anteriorly to supply the hard palate and the adjacent gingivae. The lesser palatine emerge onto the palate and turns posteriorly to supply the soft palate. Other branches run into the nasal cavity. These are the nasal nerves that provide sensory information to the walls of the nasal cavity. The nasopalatine nerve is visible, but only just as this little stump. It isn't a stump in reality, but sawing the head in half has removed most of it. The nasopalatine nerve runs down the nasal septum, which it innervates, and then goes through a foramen called the incisive foramen, because it's located just behind the incisors. It ends up innervating the anterior aspect of the hard palate, as we'll see in a few minutes. As usual, you have left and right nasopalatine nerves. You are looking at the left nasopalatine nerve in this picture. The right counterpart is running down the other side of the septum. Seeing these nerves in cadavers is not quite as easy. Let's orient ourselves first. Here we are looking at the left side of this cadaver's face. We have taken away the superficial structures and dissected down to the pterygomaxillary fossa. Here we can see the maxillary air sinus, and this arrow is pointing to the lateral aspect of the left nasal wall. Posteriorly, we can also see this large maxillary artery. If I colour in some of these structures, we'll be more likely to identify them. This is the infraorbital branch of the maxillary nerve and gives rise to the anterior superior alveolar nerve, which will go on to innervate the pulp of the central and the lateral incisor and the maxillary canine of the ipsilateral side. We can also see the zygomatic nerve, and here we have the anterior superior alveolar nerve. We can also see the posterior superior alveolar nerve, which will go on to supply the teeth of the molars and sometimes the premolars of the ipsilateral side. If we swap around the orientations, we can take a deeper look. We can see the cavernous sinus, and if I colour in the maxillary nerve and its branches, we can see just how close these are in relation. From this perspective, we can see the pterygopalatine ganglion, the pharyngeal branch, the lateral nasal nerve, and the posterior superior alveolar nerves, and the lesser and greater palatine nerves. Let's go and have a closer look at these palatine nerves. The greater palatine nerve emerges with its vein and artery through the greater palatine foramen. The lesser palatine nerve emerges with its artery and vein through the lesser palatine foramen. Looking anteriorly, we can see the nasopalatine nerve emerging just through the incisive foramen of the primary palate. As the name suggests, It emerges from the palate just behind the maxillary incisors. Here we can see the areas that the various palatine nerves supply. The greater palatine nerve is shown in purple. And as you can see, it supplies the mucosa of all of the hard palate, as well as the palatine side of the gingivae. The purple dots in the pink area, adjacent to the anterior teeth, are meant to show that the greater palatine nerve also supplies some of this area too. The nasopalatine distribution shown in pink, so it includes the anterior palate and the gingiva on the palatine side of the anterior teeth. Note that the pink of the nasopalatine nerve also has purple dots of these greater palatine nerve on it. This is because this area can be innervated by both of these nerves. Some books may not mention this. The lesser palatine nerve sensory distribution is shown in green, and this is for the soft palate. These pictures show a greater palatine nerve block, which blocks the greater palatine nerve just after it is emerged from the greater palatine foramen. You are not actually trying to stick a needle into the foramen. The greater palatine block doesn't anaesthetize any teeth, just the ipsilateral hard palate and the palatine gingiva. As the anterior aspect of the palate and the associated gingiva are also innervated by the nasopalatine nerve, the greater palatine nerve block won't anaesthetize this either. Let's have a look back at this maxillary nerve in the Pterygopalatine Fossa for a moment. We've already learned that the Pterygopalatine Ganglion hangs from the maxillary nerve here, and that the V2 fibres pass through the ganglion on their way to various places, most notably the palate. If we move a bit further along the maxillary nerve, we come to a really important couple of branches: the posterior superior alveolar nerve and the middle and the anterior superior alveolar nerves. Let's concentrate on the posterior for a second. The posterior superior alveolar nerve run down the posterior surface of the maxilla, branching as they go. Most branches enter the maxilla through tiny foramina before running immediately beneath the mucosa of the maxillary air sinus. They then form a plexus or network above the roots of each molar tooth. Branches from this superior dental plexus enter the roots of the molars to provide sensory information to these teeth, though the mesobuccal root of the first one can be supplied by another nerve, as we'll see in a few moments. Some branches of the posterior superior alveolar nerves supply the gingiva on the buccal side of the teeth that they supply, but not on the palatal side. This is the greater palatine nerve that does this. In summary, the posterior superior alveolar nerves supply the maxillary molars, though sometimes not the mesobuccal root of the first, and the associated buccal gingiva. After giving off the posterior superior alveolar nerve, the maxillary nerve passes through the inferior orbital fissure. As it passes through the inferior orbital fissure, the maxillary nerve changes its name to the infraorbital nerve. The infraorbital nerve runs forward along a groove in the orbit floor, called the infraorbital groove, which then develops a roof to form a canal, the infraorbital canal. The infraorbital nerve emerges onto the anterior aspect of the face through the infraorbital foramen. It supplies the skin on the central area of the face, including the lower eyelid, upper lip, and upper side of the nose, and the side of the nose. Just before emerging from the infraorbital foramen, the infraorbital nerve gives off a branch called the anterior superior alveolar nerve. This nerve runs beneath the mucosa of the maxillary air sinus and then joins the superior dental plexus. Nerve fibres from the ASA supply the canine and incisors and the labial gingiva associated with them, but not the palatal gingiva. When there is a middle superior alveolar nerve, it branches from the infraorbital nerve a few millimetres before the ASA. It runs beneath the mucosa of the maxillary air sinus and joins the superior dental plexus, sending fibres to the premolars and the mesobuccal root of the first molar, and to the buccal gingiva of these teeth, but not the palatal gingiva. The middle superior alveolar nerve is often absent, and various dissection studies have suggested that it is absent in 30 to 70% of the population. When absent, the nerve supplied to the structures comes from the posterior superior alveolar nerve and the anterior superior alveolar nerve. This slide shows a nice summary of the innervation of the maxillary tissues. Most left we have the vestibular gingiva, innervation for the incisors and the canine, by the anterior superior alveolar and the infraorbital nerve. When the middle superior alveolar nerve is present, it and the infraorbital nerve innervate the vestibular gingiva of the premolars, and the posterior superior alveolar nerve is supplying the vestibular gingiva for the 3 maxillary molars. Looking forwards to the middle of the diagram, we can see the palate and the lingual gingiva innervation comes from the greater palatine nerve, whilst the lingual gingiva from the incisors and the canine is supplied by the nasopalatine nerves. On the right, we can see that the superior alveolar nerve innervates their respective teeth, the anterior superior supplying the sensory innervation to the central and the lateral incisors of the canine, the middle, if present, supplying the premolars, and the posterior supplying the molars. On this image, we can see a collection of sites used for nerve blocks for the superior alveolar nerve. The posterior superior alveolar nerve can be blocked as they run through the posterior surface of the maxilla. Obviously, this anaesthetizes the structures that the nerves supply. You'll remember from Introduction to the Oral Environment, the maxillary artery runs in this posterior region to the maxilla, and that the pterygoid plexus of veins is also located in this region too. These structures are at risk when a PSA block is being administered. For example, piercing the maxillary artery will cause bleeding. This would be problematic in haemophiliac or anticoagulated patients. You may also inadvertently introduce infection to the pterygoid venous plexus, which we saw back in Introduction to the Oral Environment, communicates with a cavernous sinus which is located inside the cranial cavity. The ASA nerve can also be blocked by administering anaesthetic solution via the infraorbital foramen. This also blocks the end of the infraorbital nerve, so the skin covering the middle aspect of the anterior face will also be anaesthetized. Note that there is a risk anaesthetic solution might be inadvertently deposited into the orbit. This can temporarily paralyze some of the muscles that move the eye around. As a result, the 2 eyes can end up pointing in different directions, leading to double vision, or diplopia. Although we've mentioned a number of nerve blocks that can be applied to the maxillary nerve, you'll find that anaesthetizing structures in the upper dental arch is often achieved by local infiltration of anaesthetic solution near the structure you need to work on. This reflects the porosity of the maxillary bone, which facilitates the spread of local anaesthetic solutions. Nerve blocks do have a place. For instance, if you want to work on 2 teeth that are not adjacent to each other, or when local infiltration is contraindicated. But you shouldn't leave with the impression that they are the usual approach to maxillary dental anaesthetics. Now, before I leave you, I want to briefly address the maxillary air sinus. We've seen that the posterior, middle, and anterior superior alveolar nerves run beneath the mucosa lining the maxillary air sinus. As they are doing so, they are providing sensory innervation to the mucosa. If the mucosa becomes inflamed, such as in maxillary sinusitis, pain fibres in the nerves are stimulated. The brain can misinterpret these signals as coming from the teeth, and this is an example of referred dental pain. Referred pain is perceived as an arising from a site different to the one actually responsible for causing it. And that has brought us to the end of our journey. Let's recap the learning objectives in this video. You should now feel more confident in applying what you have learnt in this video to any self-directed study required, to describe the origin of the trigeminal nerve, describe and identify the location of the trigeminal ganglion and the apertures through which these three divisions of the nerve leave the cranial cavity, summarise the anatomy of the ophthalmic nerve, describe in detail the maxillary nerve and its branches, describe examples of dental local anaesthetics that can be applied to the branches of the maxillary nerve.